All right, welcome. This is your high-yield study guide designed to help you absolutely master the 5 key anticoagulants for your exams and, more importantly, for your clinical practice. So here's our game plan. We're going to start by comparing the heparins, then take a really deep dive into the classic Warfarin. After that, we'll cover the more modern direct thrombin inhibitors, and we'll wrap it all up with a rapid-fire review to really lock in that clinical judgment. Okay, let's jump right in with the heparin family. We're going to compare the classic, unfractionated heparin with its more predictable cousin, enoxaparin. You'll see these two injectable anticoagulants all the time. Okay, so what's the big deal here? Well, the core difference is all about the monitoring. Heparin is, let's just say, high maintenance. You need constant aPTT checks to make sure the dose is in that sweet spot. But enoxaparin, which you probably know as Lovenox, is way more predictable. It mostly just targets factor XA, and that gives it this really stable, reliable effect. So we usually don't need routine labs. That's a huge, huge difference in practice. And this is the complication we all fear with heparins. It's a true medical paradox. You're giving a drug to thin the blood, but the body has this crazy immune response that makes platelets just plummet, while at the same time, it starts forming brand new, life-threatening clots. You have to be on the lookout for this. Okay, pay close attention here, because these are make or break points for your skills checkoffs and for the NCLEX. First off, heparin's versatile. You can run it as an IV drip to treat a clot, or give it as a sub-Q shot to prevent one. Enoxaparin, sub-Q only, always. But that last point, that's the one that trips everybody up. You see that little air bubble in the pre-filled Lovenox syringe? It's there on purpose. It works like an airlock to push the entire dose of medicine deep into the tissue. So whatever you do, do not expel that air bubble. So, what happens if your patient starts bleeding? What's the plan? The antidote is protamine sulfate. Think of it like a perfect key for a lock when it comes to standard heparin. It gives you a complete reversal. But, and this is important, notice it's only a partial fix for enoxaparin. It just doesn't work as well because of Lovenox's different structure. All right, let's shift gears. We're moving away from those fast-acting injectables and over to the long-term oral anticoagulant, the classic Warfarin, which you'll also hear called Coumadin. So here's the thing you have to get about Warfarin. It's not a clot buster. Not at all. It works by slowing down the factory in the liver that makes new clotting factors. And it does that by blocking vitamin K. So really, it's all about prevention. And this slow start is a huge clinical concept. It takes a few days for the body to use up the clotting factors that are already floating around. That's why patients are often bridged. That means they'll be on a fast-acting drug, like heparin, at the same time they start taking warfarin, just until the warfarin kicks in and gets to its full therapeutic effect. I cannot stress this enough. With warfarin, patient education is everything. I mean, literally everything. They have to get their INR checked regularly to dial in that dose. They have to keep their diet consistent, so no suddenly deciding to eat a giant kale salad every day. And they absolutely have to report every single new medicine, even over-the-counter stuff, because the risk of interactions is just so high. And this right here, this is exactly why warfarin can be such a headache. Look at all those common meds. So many things can throw that INR out of its very narrow therapeutic window, which puts the patient at risk for either a serious bleed or another dangerous clot. It just requires constant vigilance. When it's time to hit the brakes on warfarin, you've basically got two speeds. For a slower, more controlled reversal, you give vitamin K. But if you're in an emergency, I mean a life-threatening bleed, you need the fast lane. And that means giving them new clotting factors directly, with either fresh frozen plasma or prothrombin complex concentrate. Okay, let's move into some of the newer kids on the block, the direct thrombin inhibitors. We're going to cover both the IV solution we use for HIT and a really common oral alternative to warfarin. So let's put these two side by side because they have really different jobs. You've got argatrobin, your IV crisis manager for when a patient develops HIT. Then you have dabigatran, an oral option that gives you anticoagulation without all that intense warfarin monitoring. And a huge plus, it actually has a specific reversal agent. So for argatrobin, the thing to burn into your brain is its main job, treating HIT. And notice, because we give it as a continuous IV drip and it has a short half-life, you need to monitor the aPTT just like you do with heparin. Also, a big one, it's cleared by the liver, so you have to be really careful with any patient who has liver problems. Now for dabigatran, also known as Pradaxa, there are two non-negotiable safety rules you have to remember. First, you must check their kidney function before starting it because it's cleared by the kidneys. Second, and listen closely, never, ever crush, chew, or open the capsule. If you do that, absorption goes through the roof and you create a massive risk for a major bleed. All right, let's pull all of this together. This is your NCLEX Clinical Judgment Hub, where we focus on what you absolutely positively have to know for your exams and for safe practice. Okay, seriously. Pause here, take a screenshot, write this down, whatever you got to do. This table is your ultimate study guide. It covers the most frequently tested facts for every single one of these drugs, the key lab to monitor, and the antidote you need in an emergency. This is pure gold. Need a way to keep all this straight when you're under pressure? Don't worry, I gotcha. Let's use some memory anchors. Just remember, heparin is high maintenance and needs close aPTT monitoring. Lovenox is low-key and usually needs less monitoring. And Warfarin wages war on vitamin K. Simple as that. Okay, this isn't just a friendly tip. This is a hard and fast rule, a major safety standard that comes straight from clinical guidelines. This is the standard of care. When you see platelets drop below this number, you have to hold meds like heparin and enoxaparin. It's a massive red flag. 100,000, that's the magic number. Etch it into your brain right now. If you see a patient's platelet count drop below 100,000 while they're on heparin, or even if it just drops by 50% from where they started, your clinical judgment alarm bells need to be ringing loud and clear. That's a huge warning sign for HIT. Okay, time for a clinical judgment check. Let's put you in the hot seat. Your patient's platelets are dropping, and now they have signs of a new clot. This is the classic picture of HIT. So what are your immediate priority actions? What's the very first thing you do? And boom, there it is. These are the 3 critical moves that show you have sound clinical judgment and know how to protect your patient. Stop the problem, communicate what's happening, and anticipate the solution. That's what it's all about. And that's our deep dive. You have the knowledge now, but remember, the real goal isn't just to memorize facts. It's to understand the why behind them. Knowing why you check that lab or why that side effect happens is what builds true clinical judgment. So go out there and apply this with confidence. You've got this.